hospitals can get into contractual relationships with partners to help them reach those goals. Don't we want to be part of that? That's the simplest way to start getting in value-based care. Show your value and then earn some of the money.
Kick it.
Welcome to Strata Stories. My name is Thomas Schreiber. I'm the Director of Marketing here at Strata PT. Strata PT combines your EMR and billing into one automated system to increase revenue and achieve a 99.99% reimbursement rate for physical, occupational, and speech therapy clinics. Recently, Strata PT was ranked the #1 EMR and billing system in outpatient therapy and rehab from Class Research. On today's episode, Paul Singh, the CEO of Strata PT, sits down to talk with Dana Strauss, a DPT and recognized policy expert and passionate voice driving the rehab industry's shift towards value-based care. Paul and Dana discuss how PTs can lead cost-saving efforts by partnering with hospitals, plus a clear financial breakdown of the value they can deliver, why RTM is under scrutiny, and how misuse is triggering increased payor audits. And lastly, how embracing the value-based care mindset can elevate your clinical impact, career growth, and financial potential. If you'd like to learn more about Strata PT and see how our EMR and billing works, head over to stratapt.com to book a demo. Now, without further delay, here's today's episode.
I was going to say, so I listen to a couple other PT podcasts here and there when I can, or I listen to recordings, and I hear, I think that there's this kind of like separation in therapist minds, or at least in my mind, I bucket into these kind of two categories. One being, therapists who are really into the more in the medical model and referrals and very kind of traditional, fee for service billing, whatever. And others who are really thinking about, okay, what are all the different ways I can monetize, and how can I not just do transactional work, but they're generally not talking about non-transactional via value-based care adding value. So as I find the through line as I listened to these podcasts is I agree with both. I feel strongly that it'll be a gigantic mistake for this profession to exit the medical model. We've talked about this before, I think. We're desperately needed, and not everyone who thinks about solutions for a lot of the things that therapists can treat are just aware of what we can do for them. So So my approach to this for therapists is we need to, genuinely and open-mindedly start interacting with others in the health system, not because we're thinking about something transactional, but because we need to spread the word about what our profession can do for the healthcare industry and organically develop those relationships where we begin to create more value and kind of everyone trusting the truth, which is the only thing that is going to solve a lot of the traditional healthcare problems is create, like, where do you create value, and then extracting that value both for patient care and the benefit of patients and their journey, and for the therapy industry, which is like wildly underpaid. We're seeing when we get patients, another theme I talk about, Paul, is like when we get to see patients, a lot of times we're seeing them more than we need to. If you think about, like, what would you do if there was, you were only reimbursed based upon how well that patient did over time, we would do something completely differently than most practices do. So the ability to add value, sort of where therapists' minds are around that, that's, I think, what my goal has become. Spread this message that we have a tremendous amount of value. We don't nearly touch the number of patients we should, that are ending up in all different avenues that cost a tremendous amount of money, that is not necessarily leading to good outcomes. And when we see patients, we're often keeping them far too long, seeing them too frequently, and not using technology appropriately. I don't want to ramble here, but there was an article yesterday about the Peterson Health Tech Institute. They put out these reports about the impact of technology on different sectors of healthcare. And they had put out a report about musculoskeletal solutions, and essentially, right, saying that the best solutions combine therapists and tech, but that they don't save money unless they're in a value-based arrangement, because therapists are generally using them and not moderating the in-person interaction time. They're just adding it on as like a RTM as an annual payment or a monthly payment, right? So their latest article that came out yesterday basically said RPM and RTM, bottom line, are being overutilized. Arts in episodes of care, they have tremendous value, but when they're just considered an add-on for every patient and they have no end point, you are now in a position where all eyes are going to be on the therapy community, or if it's RPM, the physician community, looking at why they're doing what they're doing and why these new billing codes are creating so much additional spend. Not in, I mean, yes, it's additional spend. It's not crazy like a lot of the, overspend in surgery, overspend in advanced imaging, but it's a spike in spending, and there doesn't seem to be a really great correlation between better outcomes. So why are we doing it? So
Yeah.
I know I'm rambling, so let me stop and see what what would be helpful to
I
go
think
there.
that, the thing well, first of all, I will admit, I'm probably like some of the ideas you talk about are probably way above my pay grade anyway. That being said though, every time I talk to you about this particular topic or these particular topics, I guess it's like it goes my sort of like venture capital and investor brain turns on, because I just, the way you're talking about it is like it's something that will probably fly over most practice owners' heads, because most of them are not multi-practice locations with 50 clinicians. Like those people have figured out the level of business acumen required to like keep the lights on and build a team and all that, enough so that they can then start to like think about this, what you're talking about. And I always, as soon as I hear you talking about this, I'm like, man, this is just like the tech world was 15 years ago. We were talking to tech. You had these like really intelligent people talking about like what tech could do. And on the other side, you had a bunch of like very technical founders, regardless of age. You had very technical founders that were trying to build these businesses up. And I remember, and I'm saying this with the clarity of hindsight, but I was just flailing a bit back then too. And I just remember thinking like, what is the modern day business school for these tech companies? Because traditional MBAs, I think, are wonderful. There's nothing wrong with them, but often these MBA candidates have learned and studied maybe larger organizations, and how those large organizations solve problems. But those are very different problems than, the startups. So I remember one of the earliest things we did was like I ended up creating we called them accelerators, because we didn't want to call them incubators. All these states have like incubators, like stay here in the nest and stay warm and cozy. We call them accelerators, where we're like, hey, here's $50,000, here's $100,000. You're going to spend 90 days working on this idea full time. We're not guaranteeing you success, by the way. We're going to teach you all the skills you need and only the skills you need to get from wherever you are to, let's say, $500,000, $1 million in annual revenue. And if you can do that, then these topics become much more easy to digest, because now you've built the base. And so I'm rambling now too. I apologize, but it's like whenever I talk to you, I always come back to this idea of like, man, what would that modern day accelerator look like for practice owners? And this is maybe more of a rhetorical statement, because I'm diverging off of what you're talking about, but there's a compliment in there somewhere, by the way. But I think ultimately, yeah, there's a compliment in there somewhere. I think anyway, the bottom line is I don't know that I have enough, experience, at least as a clinician of any type, because I've never been one, to have an opinion there. But at the same time, like as a, self-described blood-sucking capitalist, I think the reality is that it shouldn't be this hard for practice owners to make a living and clinicians to make a living. And certainly some businesses have figured it out. I won't throw anybody. I won't name names unless it's okay with you and the other person. But I know at least one person that you talk to, and I'm not trying to be cagey. You'll know who I'm talking about. One of the folks that I think that I can't remember if we introduced you to him or he heard you on our podcast and reached out to you, but he's in Florida. You probably know who I'm talking about. I saw him announced somewhere, maybe it was on some email list or something. He was like, yeah, now all of our clinics are members of this group and that group. And I was like, oh, he's been talking to Dana. Okay, here we
chat.
yeah.
Uh-huh.
Yeah. I was like,
If you
I could see
pay good
Dana's
enough
fingerprints all over it.
That's it. I'm hoping that's what it is. I can't wait to. Yeah, I texted him when I was at the conference I was just at and said, "Hey, let's chat. I bet this is what this is
Yeah.
about."
Yeah. But I think like this is the thing, right? And again, I'm not to anybody listening, I'm not trying to be cagey, but like it's his news to share. And Dana, I don't want you to anything you guys talked about is private, but here's the thing. It's like, I could see your fingerprints all over it because I've known that practice owner for a long time. He's a great client of ours, been here since the beginning, really. Um, I think like 6 months ago, he probably, if you'd said, "Hey, are you going to join these groups or do these things?" He probably would have been like, "I don't know." I don't know. But, I think you've impressed upon, I think, a certain level, you basically impressed or pushed this idea, rightfully so, that, if you can't, if you're not part of these groups, if you're not at the table with these decision makers, you're not going to be able to be in the conversation and frankly, not even be able to benefit from, whatever's happening. So, um,
I think, Paul, therapists don't know how far behind the rest of the industry and healthcare is in knowing what we're capable of, value we're capable of adding. Meaning, you know how they say you make assumptions, you make an ass out of you and me. I think we are, as an industry, so deep in the assumption bucket that we have kind of turned. I'll explain what I mean after I say this. We've kind of turned it as we're on the defensive, right? Like, so the way I think about it is this: a way I've thought about all of value when I use the term value based care all the time. But what I essentially mean is doing more of what creates more longitudinal value for patients and for the health system so we get better outcomes. That's the bottom line, right? But I think about it like this: therapists are never going to survive making at the max $100 an hour or per visit, right? It's just it's a dead end. It's not going. That's only going to get worse, not better, if we think that fee for service is going to be the solution for this profession. It is just not. So for therapists to have a general idea of the landscape, I'm then counting on them to start thinking innovatively, like this therapist that you brought up, who I think we're both talking about. Meaning, if you can grab onto the concept that it is not intentional, that the physician community or the health system community does not realize that if you take us and put us in front of patients sooner when they have pain and movement problems and the gait issues, et cetera, if you put us in front of them immediately and you then compare that same type of person to another one that gets sent right to an ortho and has a CT scan and has aspiration and has like some other intervention, then you look at the outcomes compared to the spend. It is a stark market difference. And there are smart people that care a lot about that. We have to get that information in a digestible way using the same data that those who are looking at these things are comfortable with, bring it to them. And then once we prove our capability, then we get into different types of arrangements where we're being reimbursed because we are avoiding other care. And that's, I talk a lot about PT and primary care for a good reason. Primary care brings much, much more revenue to the primary care site when and if they create more value to the health system, to the payer. Really, what we're talking about is the payer. The hospitals, they very hard time winning in the situation. Our job and where we can earn more money from the payers is by showing, simply in the same way, using claims data, using avoidance data, showing payers, showing at-risk providers how we prevent the spend that they don't want to pay for. That's it, right? Physical therapy intervention at the right point in time in the place where therapists or patients are already going avoids high cost specialty care. The worst, the most difficult specialty care to get control of, I would argue, is MSK, because the variability is like this. It's all over the place. And when things are highly variable, give a more, predictable solution, we win. But we have to be willing to think that way. Think the way payers and at-risk providers are thinking and simplify this, right? So anyway, my soapbox as usual. So Israel.
No, no. I mean, look, I think that this is what people need to be thinking about. I mean, okay, so maybe I'll say this in an assertive way, and then you can kind of either refute it or add to it. But like, I don't think you're on a soapbox. I think if I had to like, throw a dart at the wall and maybe pick a milestone, I would say, I think that any practice owner, regardless of number of locations or number of clinicians or whatever, I think any practice owner that is grossing, I don't know, let's pick a number. Let's say any practice owner grossing 500 grand a year on their business, grossing, not profiting, but grossing 500, like you've got enough patients and stuff like that to hit a number like that. I think you should be spending 20% of your time thinking about this kind of stuff, because the team you have to then build to in the processes you have to build to go from, let's say, that $500,000 sort of stake in the ground to whatever your aspirations might be. You kind of have to start with the end in mind. And I think that to me is kind of thinking about the conversations you're having, and then choosing whether or not that's right for you, wrong for you, what you agree with, what you don't. I think far too many people. Okay, so just as a little tangent, because I think of businesses as like machines that you can build, and I know they're full of people and personalities. I know those things. I'm not like a cold, callous person. I just think of businesses as machines. And what's interesting is, if you. So I think I told you in the pre-show. I've personally invested in a little over 3,200 companies over the last 20 years, primarily in the tech space, but the trends hold, because we've also invested in like restaurants, bars, things like that. So here's an interesting stat. So when you think about returns, like money coming out, um, and you think about returns as a proxy, meaning like, I know everybody's got a different version of what success is: freedom, power, notability, whatever, right? But let's just use money as a proxy to measure success. What's interesting is, if you plot an XY graph, a two-dimensional graph, and you plot the number of years it takes for the investor to get a return on their money. What's really fascinating is, and this is true of restaurants, bars, childcare centers, technology companies. My wife and I have invested in all of these industries. Here's what's interesting. If you plot them out, it it looks like a camel's back. Like people actually think, I think people think that like you just invest and then magically money shows up and everybody IPOs. But actually, if you plot it out and you say, okay, the where the XY axis meets is the 0 point, like that's the day you invest. So here's the interesting part. If you then ask yourself, what does the return profile look like? It looks like a camel's back. And the two humps are basically at the 2-year mark and the 10-year mark. And there's a point to this, meaning you invest in something, the founders or the owners grow it or whatever. If they're growing really fast and they're building something really interesting, often they get acquired or something big happens around the 2-year mark, and then the investors and everybody's happy. Okay, now I'm going to come back to the trough, because then you come back down here, after the 2-year mark, kind of goes here, and then sometimes over like at the 10-year mark, a much bigger hump appears, and you get much bigger exits right there. Those two humps are really cool, but the point I want to bring up that I think is applicable to maybe the ideas that we're talking about here is that there's a trough. I call it the trough of despair. Right in the middle is the trough of despair. And most companies at that stage, that have survived for 2 years, tend to then plateau as a company. They plateau with revenue, they plateau. And then we call it the trough of despair, because when they get bored or they get frustrated, their operational excellence sort of drops. Like they almost get too
You
tired to
dropped the
do all the
ball.
things. Right. So where I'm going with this is that like this conversation you're talking about is, I think, very valuable to practice owners that have, I would say, have either $500,000 in gross revenues or probably have been running for about 2 years. And if more people could start thinking about these kinds of topics, I think far fewer practice owners would, complain about the exit valuations they're getting. In other words, it's almost like the tail's wagging the dog right now, right? So in the sense that like the practice owners, I mean, I'm sure you've met people like this too, but I definitely meet a lot of people every month that are publicly they're like, oh man, we're crushing it. And then, you have a conversation like this behind the scenes, and once the guard's down, they're like, man, this sucks. Like my margins are low. And like, if I try to like hire somebody so that I can hang out, like all my margins are gone. And if I try to sell it as it is, I might get 1x my profit, which is, we agree, is like nothing. And so that's, but the thing is like, I always kind of like, I try to be there like Tony Robbins sometimes, even though I have no stake in it. I'm like, guys, remember the thing that it takes to, sell the business or is actually the same thing you got to do to grow the business. And anyway, blah, blah, blah. The point is, I don't think you're on a soapbox. I just think that you're, um, I think more people need to actually tune into this kind of stuff, the stuff you're talking about. I could imagine. Well, I'll just tell you right now, and then you can say no privately later. I was just thinking as I was listening to you talk, I was like, man, we're ramping up our conference activities this year. I actually just got accepted for a talk that I'll be doing at PPS in November, whenever that is. Yeah, thanks. Yeah, I think I told you what I was talking. Anyway, so yeah, I was going to basically use the same. I was going to basically do I got approved to do a talk on, how to get ready to exit for practices. But I'm drawing from all the experience of tech companies and the ones that are our customers at Strata. Um, anyway, the point is, you can say no to this later. But as you were talking, I was like, man, I wonder. We've got a pretty decent booth there this year. We should probably like figure out how to do like a round table for 30 minutes with your audience, our audience, and talk about these things. Because a bunch of our clients are going to be there. And I mean, you know how it is. So you can totally say no privately, but now I put you on the spot publicly. So,
I mean, there's like a few percent of therapists who are gonna latch onto this. I wish it was greater, but it always is gonna take just a few to show, oh, this is what she means tangibly. I know it's easy to say, she's just theoretical, that she's not actually doing the work. But that's true. But I can easily say completely truthfully that I have watched this transformation take 10 years for primary care, and still we're only at a relatively small percentage of primary care that has transformed into advanced primary care, is taking full risk, and is now many of these practices are making double and more what they were making before because they are saving for the payer so much in downstream care. What I know is two things. Therapists haven't even begun to think about this to any degree. Some physicians have, like Mark Gruner and Eric Mankini. They're thinking about how do we leverage physical therapy in the value-based space to extract value and contract with payers. Therapists, I don't know a therapist that's in that space, but they're doing it. And what I know for sure is that this is a lack of knowledge on the part of advanced primary care practices, knowing what we're capable of and knowing how to work with us. And it's assumptions that therapists are making about why and how other players in the health system are going to help them make more money, understanding the incentives that completely shift. Right. And I try to say this, and how, like, there's a core message you want to get across. And if you figure out the right way to reach somebody by saying it a different way, but I'm that way, like I could hear something 10 times and then someone says it in a way that relates to me. And I'm like, oh, that's what they mean. Right. That's what they're talking about. But so I'll try to say it this way this time. For a primary care practice that I've spoken to many, and they say, we want to work with, we understand, we know it would be so much easier if we had a therapist that we just knew we can just get the patient to them and let them like see the patient instead of telling them to go and having them end up in ortho. They don't know how, and they haven't been exposed enough to even know the questions to ask, to say, well, what is possible? What could you do for us or with us? Right. But what we know is that there are these physicians that are going to payers and saying, okay, let's take a physical therapy eval as a trigger for an episode. And let's compare that to an episode triggered by like an orthopedic visit. And then let's look at the difference between the spend and the quality and the outcomes. And then we're going to make an agreement that you're going to give us a bonus when we save or we redirect dollars X amount over a period of time. Therapists don't even have to do very much to make that the reality. It's just, we know when therapists get to patients sooner, that avoids high cost care, and payers care a lot about that, and at-risk providers care a lot about that. We just have to show them and then make it super easy and accessible to reach us. If that's somebody triaging in a practice, if that's hours that are much easier, if we'll go to the home and do the evaluation, low friction, make it simple, be the partner and understand what their incentives and friction points are. If you want to partner with somebody, well, understand what they get out of it. I'm sure this resonates with you as a venture capitalist. What is going to resonate with that person I want to make a deal with? What do they care about? What are their incentives? And then meet those needs. Like, and then all the rest of the stuff, the things that seem complicated, they fall into place, right? There are things we can learn from there. But anyway, I'll see what you think of those things.
You were, as you were talking about that, I'm trying to, my words aren't coming out today. Um, you were saying something in there, and I think the key idea that I think really resonates with me is this idea that I interpreted what you were saying as the key idea being that, like, there's the facts, but it's the delivery that really matters. So in other words, like, these are like big topics. These are like really complex things we're talking about here, but often it's in the delivery. It's the best way for me to explain what the key idea I got from you is to maybe like use an example. It's like, if I'm personally at the doctor and the doctor uses big words and, whatever, that are clinically accurate, but me, the normal human being, is just like, what in the world is going on? The delivery actually screwed up the help that clinician was trying to give me. And conversely, a doctor saying like, hey, look, I can give you the fancy words, but here's the reason your knee is bothering you. And here's what we should do about it. Like, it's all in that delivery. And I think I know I'm like, it probably feels like I'm like off topic on you, but the thing is, like, this is the thing. This is so, like, when we think about even like those modern day business school ideas that we talked about, I'm not telling anybody. I mean, we still operate those, by the way. Like, it's not like a 15-year-old abstract concept. We still run cohorts 3 times a year. We have a whole team around this. And the point is, like, what we tell people is no different than what any other investor, coach, consultant tells them. Instead, the difference is we just convey it very bluntly. And anybody that's been in more than one meeting with me knows that the phrase I use over and over is like, we're going to talk like second graders. And it's not meant to be disrespectful. You have to simplify here, right? Because
You got to get
so
the
and that
concept first to know how to act, right?
Right, and that's where I think, and here's and I genuinely mean this, a genuine compliment for you. I think that of all the people I've met that talk about these concepts, I think you have the sort of the presence and the ability to kind of like make the topic relatable. And I think there's something really powerful in that. And that's why it's, and I've said this to you, before, even when the recording link is off, it's like, I think even though you and I don't have a business relationship, I think the reality is this message has to get out. Like, whatever, the stuff you're talking about, more people have to hear it.
It will help your clients. There will be some that I hope will come back and say, this is what planted the seed for me. This is why I did it. If they like think back to, okay, where did the root, and I mean, as I'd bet the moon on that I'm right. And I don't mean to sound cocky there. I mean to say I've predicted pretty much all of what we've seen happen in the value-based care space. I haven't predicted the timeline perfectly because it's impossible, but I'm as sure as I can be that what I'm saying is essentially what's going to happen. Timeline, I don't know. But so let me do a little bit of, it's a carrot and stick. So let me give a little bit of, like, put a little bit of fear into therapists with this, which I think probably your listeners will find interesting. So I don't know if anybody was paying attention to the therapy world. I think the person that we were talking about that's looking into some novel ideas is paying attention. But on last Friday, so a week ago, CMS put out their first round of payment updates since the new administration, right? And they put them all out in one day. The IPPS, the inpatient payment system proposed rule, the skilled nursing facility proposed rule, the inpatient rehab proposed rule, the hospice proposed rule, the inpatient psych proposed rule. So take a look at those and get an idea of what's coming, okay? Here's what's coming. We're not giving more money. Like, money, forget it. Just the CMS is their priority is not worrying about giving providers more money. They gave a low payment update to everyone. IPPS was about 2.4%. That's not going to be more generous. They need to get more money out of this. Like, they don't need to give more money. They need to save more money. So don't expect good payment updates. It's not going to happen. You're going to make more money if you decide how to create more value in the system. We also saw an update again, a fraction of therapists I think are paying attention to this, a very small fraction. And I would urge them to please pay attention to the team model. Okay. The team model, the transforming episode accountability model, is an episodic model that allows hospitals to contract with outpatient therapy practices. It's called out in the actual proposed rule of the final rule, and nothing has changed about that. This model, right, says CMS says, okay, hospitals, we're going to take these 5 sets of surgical episodes that we know from R&D over the last 10 years annually is saving us money when we say, you're going to be responsible for all the spend that happens outside the hospital. We're going to hold you accountable. When that's over what we expect the spend to be for 30 days after the hospital, you are going to pay us back. We are going to put you in a place where you care more about what happens to people when they walk out your door, right? Well, I don't know providers better suited to advise hospitals to get into like high value relationships and contract with hospitals than therapists. We don't want those hospitals do not want patients going to skilled nursing. It drains the bank right away, right? If you, I'm going to give a ballpark example because I want to give something concrete to latch onto here. If a total knee replacement, right, is they're estimating that an episode for the surgery and 30 days after, they're estimating it should be $21,000, making up a number. And you send them to skilled nursing, they keep them for 30 days. And now that spend is $30,000. Okay. That hospital has to write a check to CMS for $9,000 because it was $9,000 more than what they say should be the expected spend for that patient based upon how they calculate individual target prices for an episode. That is opportunity. If I'm a therapist, right, what do I know? I know what level of mobility and support patients need. I should be able to give an excellent, better than anyone, rehab prognosis. I should be able to identify what's the lowest level of support they could have and do well with. And many, many, many more patients, if they're evaluated well, will be coming right home to start with at-home PT in the home, right? Outpatient PT in the home. Some home health, a lot outpatient PT. Well, we make an assumption that hospitals know how to send the right patients to the right places. They've never been incentivized to care at all. It's not how they're paid. Their incentives are to get patients out fast. That has nothing to do with identifying the best site of care. We should be helping hospitals develop mobility programs so patients are, everyone, the family, the patient feel confident, get them home. We should be demonstrating how quickly and easily we can give them access to care in the home, how we'll be there that day that they arrive. The therapist will be in their home within an hour, right? If we could do those 2 things alone. Oh, and third, make sure that they get back, because one of the measures that they're going to hold the hospitals responsible for is making sure they get back to their physician within 30 days. Help them get that scheduled and figure out who's going to get them there. Yes, is that in like our top wheelhouse? Well, maybe no, but who else is better at making sure they can do that car transfer, in making sure the family knows how to get them up and out of a chair? Value is there ready for us to take it, but I haven't heard any therapists even speaking about this. It's right in the rule that contract with outpatient therapy departments. Have you heard one person besides me mentioning this? There's money to be had there because there's a
Right.
lot of upside.
Right.
On the converse, if the episode 21,000 target price and they only spend 15, the hospital keeps the remainder. CMS pays them back because they did better than what they expected. Hospitals can get into contractual relationships with partners to help them reach those goals. Don't we want to be part of that? That's the simplest way to start getting in value-based care. Show your value and then earn some of the money.
Well, and that's the thing is the most the thing you said there when you started just you sort of casually just mentioned numbers. You mentioned like 9,000 here, 21,000 there. I think that is what really is going to catch some attention here because I don't, it's one of those things where like, I imagine if I put 10 practice owners in front of you and said, listen to Dana, they'd be like, okay, cool, whatever, and then, and you would be factually correct in everything you tell them. But if I reframed it and I said, here's an example where there's $9,000 just sitting there waiting for you to take it, I think all of a sudden everybody leans forward because as you know, a lot of these clinicians that are not thinking about this are thinking, okay, if I get them in the door and they have this payer, I could probably get $107 per visit, and that's important, right? You got to start somewhere. But when we think about these kinds of topics, like the reason you're getting so excited about it and the reason you've spent so much of your career thinking about it is not, I mean, you might actually be like a policy nerd and like to read it, but the reality is there's big money around it.
That's
And
right.
so,
I
so
figured out what do people care about? What are people not paying attention to? Oh, this is not that hard. People just think it's so hard. It's not that complicated. And there are very few. And here's the other thing I would say to therapists: learn a little bit about it, and you're going to know more than most of the hospitals know. Right? It's not that complicated. You need to know some base terminology, but you can learn that. I mean, I learned almost all of it by doing like attending webinars and Googling and reading and talking to people. It's not that difficult. It sounds scary and it's not scary. So the other thing is you have hospitals willing to pay a tremendous amount of money to consultants to tell them what to do. If you as a therapist can get some general knowledge about how these programs work, you can be a lot of support, far more than the base level I'm suggesting, which is to get into some simple contracts to either help train the therapy staff, to develop a contractual relationship based on outcomes, whatever. But there's a lot more you can do, and realize consultants are just learning it too, right? Like there's a couple of big consulting firms that have been in this kind of episodic space for a while. They'll continue to sign clients, but they're very costly. And if we could provide some value, it could become the first of many steps in getting into this space and extracting that value, because someone is going to extract it, right? Why not be us?
Thanks for listening to another episode of Strata Stories. Strata PT combines your EMR and billing into one automated system to increase revenue and achieve a 99.99% reimbursement rate for physical, occupational, and speech therapy clinics. If you'd like to learn more about Strata PT and see how our EMR and billing services work, head over to stratapt.com to book a demo.